Honorable panelists, respected audience, Assalamu alaikum. I am Dr. Habiba Firdausi, presenting my case entitled It Always Seems Impossible Until It's Done When the Options Are Limited During the Storm. Our patient, 47 years old, non-smoker, non-hypertensive, non-diabetic, Bangladeshi, had been working in Middle East for the last 15 years. History of pacemaker implantation, single chamber, 2 years back in the Middle East. That time, his diagnosis was dilated cardiomyopathy with complete heart block with ejection fraction 30%. His coronary angiogram was normal. Recommendation was cardiac resynchronization therapy, but single chamber pacemaker was implanted as it was free and paid by his company and sent him to Bangladesh. And he came to our hospital with the complaints of shortness of breath, chest pain, sweating, and was hemodynamically unstable. And the rhythm was monomorphic VT. So synchronized DC cardioversion done and return to spontaneous circulation was achieved. He had the same episodes of hospitalization for 2 times within last 1 year and reverted by sinus synchronized DC cardioversion. On the next morning, he again developed monomorphic VT, but this time patient was hemodynamically stable. So we started injection amiodarone, bolus, then maintenance, but rhythm didn't revert. Then injection lignocaine, magnesium sulfate were tried, but to no avail. So he was subsequently given desynchronized DC cardioversion and normal sinus rhythm was achieved. By this time, workup done, that is echocardiogram shows dilated LV with global hypokinesia and ejection fraction 25%. His cardiac enzyme assay was normal. Electrolytes, thyroid function, anemias were excluded as triggering factor. But alas, after 1 day, he again developed monomorphic VT and patient was hemodynamically stable. So this time, we started injection lignocaine and returned to normal sinus rhythm immediately. So after seeing this response, we started oral mexiletine. Patient was arrhythmia-free for the next 2 days. But he went into monomorphic VT 8 times on the day 7th and was reverted only with increasing dose of synchronized cardioversion each time. Sedation with fentanyl and midazolam also given, but this time we really become hopeless. So decision was made to try sympatholysis with percutaneous left sympathetic ganglion block. So after checking coagulation parameters and explaining procedures to the patient and relatives, taking due consent, the procedure was performed under ultrasound guidance. And finally, the patient was arrhythmia-free and we kept him on oral mexiletine. So on day 15th, we discharged him with a plan to implant CRTD. We couldn't plan for RFA because 3D system was not available. And after 2 weeks, we implanted cardiac resynchronization therapy. It has been 9 months followed up. In echo, ejection fraction improved and patient is clinically improved. Now he is on optimal heart failure medication. So what is known regarding electrical storm? The exact definition of a storm is still debated, but the most widely accepted one is 3 or more episodes of VT and VA over 24 hours, each requiring therapeutic intervention, including ICD therapy and incessant VT lasting more than 12 hours. So early recognition and prompt treatment is crucial. So what are the options of treatment? Here we can see acute phase stabilization followed by subacute or chronic phase management with more advanced therapy like radiofrequency ablation or surgical sympathectomy. In acute phase stabilization, if recurrence occur, we can use percutaneous left stellate ganglion block. And PLSCGB is now recommended by 2022 European guideline, class 2B indication based on strong pathophysiological rationale and the very promising preliminary clinical data. So actually, I want to focus on only 2 treatment options here, beta blockers and percutaneous left stellate ganglion block, because it is well established that autonomic nervous system plays a crucial role in genesis and maintenance of electrical storm. And beta blocker have the pivotal role suppressing sympathetic activity, but have several shortcomings, like sympathetic nervous system involves multiple non-adrenergic pathways and neuromodulators, which are unaffected by this medication. Additionally, there are 2 receptors which is untouched by this cardioselective beta blocker blockers appears to play an integral pro-arrhythmic role as well. So these shortcomings can be overcome in some sort by non-selective beta blockers like propranolol or nadolol, and more definitively by left sympathetic cardiac denervation. Which is a surgical procedure, but it is difficult to perform during an electrical storm. So PLSGB can be a temporary, potentially life-saving rescue option. Several studies have shown it's a promising treatment. So, in conclusion, we can say percutaneous left atrial ganglion block is currently the least invasive ultrasound-guided, effective and safe method for terminating electrical storm. And increasing awareness and experience among the cardiologists will allow more patients to benefit from these procedures, especially when other modalities treatments have failed, or it can be used as breeze therapy before catheter ablation. So I would like to acknowledge my unit chief, Dr. Monsurul Haq sir, who allow me and keep faith on me, and also my friend Muhammad Ahad Hossein, is an anesthesiologist and pain specialist. And please keep hydrated yourself in this scorching heat. So thank you.
Thank you, Dr. Habiba.